Hello everyone, now we continue with our discussions to crack down the long case scenarios into very small lines. So this is what we're gonna do. You see somebody who's 63-year-old man comes in with dyspnea, orthopnea and crackles. There is cardiomegaly and vascular congestion. And so the answer is, what is the proper procedural intervention to prevent kidney injury? How to prevent renal injury for heart cath. So sometimes if somebody's like fluid depleted, you give them fluid to prevent renal injury. But this patient's already fluid overloaded. Are you going to give them fluid? So that's the answer. The answer, do you give them fluid or Lasix? No, this one you give Lasix. You optimize their volume, because too much volume, kidney injury. Less volume, kidney injury. So really you want to, that's the trick, is you want to keep a fine balance. So contrast acute kidney injury, usually creatinine elevation 24 to 48 hours after arterial contrast administration, and gradual return to baseline within 3 to 7 days. Risk factors: if you have kidney disease, high contrast load, hypovolemia, and NSAID use, and usually caused by pre-renal vasoconstriction and direct tubular cytotoxicity by the contrast. How do you diagnose it? A fraction excretion of sodium less than 1%. You can see muddy brown granular cast on the urine houses and patchy necrosis of kidney on the biopsy. What you want to do, you want to optimize renal function, 0.9% saline, hold NSAID, use lowest volume of contrast agent possible. Okay, this is what you want to do. This is how you treat that patient. Okay. So optimize their volume. Okay. Now there's this other case. 44 have renal failure on Bactrim. Okay. So and they tell you, okay, why creatinine is high? Why the creatinine is high? This is tubular effect of trimethoprim. Trimethoprim compete with creatine and causes false elevation in creatine. It's not an actual kidney injury, but it causes elevated creatine without decreasing GFR. Okay, that's the key in this case. Okay. Now you have a patient who have productive cough and interstitial nephritis. Okay, 33-year-old, HIV, cough, and there's interstitial and filtrate. So what do you treat? What do you treat with this patient? You treat with IV trimethoprim sulfamethoxazole, IV Bactrim. Okay. So what do you need to monitor? What do you do? What to do now? Monitor for hyperkalemia, because this is one of the side effects. If somebody on IV Bactrim can cause hyperkalemia. Bactrim is commonly used drug, so you need one has a lot of side effects. So you need to know the side effects. Could cause skin, hematologic, and renal side effects. Skin causes Stevens-Jones syndrome, toxic epidermal necrolysis, and exfoliative dermatitis. Hematologic causes megaloblastic pancytopenia, folate deficiency, and renal side effect causes hyperkalemia, impaired tubular secretion of creatine without affecting GFR, like the previous question, crystalluria, and interstitial nephritis. So you gotta watch out for these side effects of the medications. Okay. Now this another case. You see 33 with a flank pain, renal stone. Best next step, urology evaluation to remove the stone. Why? Because there is symptomatic urethral stone. If there is urosepsis, acute renal failure, or complete obstruction, urology evaluation immediately. If there is none of that, there is no sepsis, no renal failure, no obstruction, it's based on the size. If there is more than 10 millimeter, like in this case, you just urology consult. If it's less than 10 millimeter, you start with hydration, pain control, alpha blockers, and strain urine, and then you do and then you monitor symptoms. If there's still pain and the stone doesn't pass within 4 to 6 weeks, you just consult urology. Okay. So somebody in the ER usually they just hydrate them, follow up with urology as an outpatient. If they come back still having the pain, they admit it, consult urology. So that's why as an internal medicine, anytime I see that patient, you just admit, consult urology, because it's usually failed outpatient therapy. Alright. Now you have this patient who have rheumatoid arthritis. So you see 51 with the rheumatoid arthritis symptoms. They tell you, okay, swollen fingers, nodules over the elbows as well. Okay, nodules on elbows is a good one with rheumatoid arthritis. They tell you what's best next step before starting treatment. What do? You do TB skin test. Why? Because you're gonna start some, and they failed methotrexate. Okay, if they failed methotrexate and they're still not controlled despite being on that, so what do? You're gonna start the DMARD. Okay, so you want to do TB skin test. So rheumatoid arthritis, first you start methotrexate. If it's persistent symptoms after 6 months with on methotrexate, you do step-up therapy. You do TNF inhibitor, okay, or you do parallel therapy, like you add non-biologic, you add sulfasalazine or hydroxychloroquine. If it's still not controlled on methotrexate, sulfasalazine, you add the TNF inhibitors. Before you do that, you do TB skin test, and then you can, if that doesn't work, you switch to alternative TNF inhibitor and continue methotrexate as well. Okay. Other things that you want to screen for before TNF inhibitors, this is common because that's why you need to know about that. Check for hepatitis B virus, hepatitis C virus, okay? These are things that you want to check because they weaken your immune system, okay? Okay, now to summarize what we discussed that before starting TNF inhibitor, you do TB skin test, hepatitis B virus. You do urology evaluation if there is a flank pain, renal stone, more than 5 millimeter renal stone. Somebody on IV Bactrim, you're going to monitor for hyperkalemia. There are a lot of side effects for Bactrim, including skin, anemia, hyperkalemia, nephritis. Can also raise creatine without affecting kidney function. You give Lasix before doing cath with contrast. So because you want to have a good volume, your patient euvolemic before starting doing contrast to the kidney, because too little volume, too much volume, it's not good. So always you want things in the right balance, and that's kind of in general in medicine. Like high calcium, low calcium, it's high or down. This is like why the patient comes to you. Either calcium up and down, potassium up and down, sodium, acidosis up and down, and your job is to maintain that fine balance. Fluid overload or dehydration, either fluid up and down, a lot of these things that you deal with, okay, is due to patient deviate from the fine balance that God created. So you want to bring it back to the balance, doing your best to bring it back to the balance. And that concludes our discussion for this session. Thank you for listening, and we'll see you on the next one.